Thank you very much. I'd like to thank Madam President for inviting me, and I am pleased to be at this wonderful meeting. This is kind of a different talk. It's not exactly a talk on AI and radiomics, because in many ways, as I hope to try to convince you, the issue and the challenge to radiology is not artificial intelligence or radiomics, but rather, in some ways, I will try to make the argument that we modern radiologists have lost our way. I start my talk usually in this topic about my dad. My dad was a radiologist. He was vice chairman of radiology at the University of Kansas in the States. And at his retirement party a number of years ago, there was a celebration of his career. A lot of alcohol was served. And at the near the end, I came to him and I said, well, Dad, you know, you should feel very good about all these people celebrating your career as a radiologist. And he looked at me and he said, well, I'm just glad I'm retiring. And I told him, why? You're still relatively young. You could still practice radiology. And he looked at me and he pointed his finger at me and said, because you ruined radiology. Now, I thought he meant my generation. We weren't working as hard as his generation, but he didn't say that. He said, no, you misunderstand. You, my only son, destroyed radiology. You and the rest of you PACS people. I never heard of that because my initial research, my early research was in developing PACS, digital image management. And I thought that was a good thing. And he actually said, no, PACS was a terrible thing for radiology. Before PACS, we radiologists were more respected. Before PACS, before IT, we in radiology were the doctor's doctor. I had never heard that term before. How many of you have heard that term, that radiologists were referred to as the doctor's doctor? I had never heard of that. You have to be pretty old to actually hear that. And what he was talking about was the fact that back then, before PACS, before advanced IT, certainly before artificial intelligence, we were film-based. But in many ways, even though film-based interpretation by radiologists was inefficient, in many ways, we radiologists were much more collaborative. We were more clinical partners. Many of you in the audience, you look very, very young. How many of you remember radiology before PACS? Few people, few older people. Radiology back then was different. The radiology reading room were very busy places, very loud, very crowded, because medicine began in radiology. The surgeon, I remember that when I was a resident. I had to wake up very early because I knew at 6 in the morning the surgeons would come. And then after that, the medicine people. How many remember those days? Those days were very rich. We collaborated multiple times a day. Yes, for you young people, very inefficient. Now you don't have to come at 6 in the morning unless you're an interventionalist. But back then, we had much richer communication. No one read our reports. That was a good thing because back then report turnaround time was measured in days. But reports were just formalities. We actually communicated and collaborated several times a day. The report was secondary to personal interaction. I will make the argument that my father's generation, when we were the doctor's doctor, before digital image management, before AI, before advanced information technology, we provided more precise medicine back then. We hear now about precision medicine, and I'll go into that in a bit. In many ways, I will make the argument that even though it was inefficient, back then we were more precise, we were more patient-specific, we were more valued. I will make the argument that today, modern radiology, in some ways, we have lost our way. Digital image radiology is certainly more efficient, no question. But we are increasingly isolated from our clinical colleagues. We sit in our reading rooms, are now nice and quiet places, where our reports are messages in the bottle. I hope you read my report, but we basically don't interact anymore. We frequently have an incomplete understanding of the patient's clinical context. We before knew everything about the patient because our clinical colleagues talked to us several times a day. Now they barely tell us anything. So our reports, we are incomplete observers. We are imperfect interpreters. And as such, Bayes' theorem applies. We need clinical context. That is the prior probability that allows us to interpret images. We have lost that. We are no longer truly collaborative. We are overly dependent on this message in the bottle that we create and throw over the wall, and hopefully our clinical colleagues talk to us. As a result, I will make the argument that we modern radiologists are frequently imprecise. We are not patient-specific, and we certainly are not impactful. So we need some help. In order to be the doctor's doctor again in this next generation, as you talk about the challenges of radiology in Thailand 4.0, which I think is an apt title. It's a good goal. We need help, because right now I will make the argument that current radiology is barely sustainable. As I travel around the world, a common theme I see is radiologists being burnt out, working too hard, but being less valued. It's not just the fact that our image data sets are larger or increasing to the point, but they are getting larger and increasing to the point that existing IT systems, the PAC systems that we have, the other information electronic systems that we have, and human radiologists can barely hang on. There's too much emphasis on time-consuming image manipulation and tedious tasks that results in variability and fatigue, and as I said, burnout. We're spending too much time interacting with primitive tools on our systems and we've lost our way. We do not see the big picture, which is the patient. Always should be the patient. We are now manipulating images. We're doing things that should be better done by machine. And as a result, we're having difficulty addressing the increasingly specific demands that our clinical colleagues are asking. They are practicing precision medicine. Precision medicine demands precision radiology, and we can't provide it. We barely have the resources to do what we're doing, and that's a problem. And I think that's the reason why you asked me to talk about AI, deep learning, and radiomics. Now, I will make the argument, I'm not going to talk a lot about that. Okay, tomorrow you're going to have a very good talk tomorrow about that from other speakers. But I'm going to tell you in this talk, there's a reason why there's so much interest worldwide in concepts like radiomics and artificial intelligence. Because even though they are overhyped, overpromised, and I will make some discussion on why it's going to, these are still very early times, they are reflective of two major, very important drivers and realities to our practice that we have to encounter. The fact that we're interested in radiomics, even though I will make the confession that I believe that a lot of radiomics is suspect right now, the concept of radiomics speaks to the ever-increasing requirement for improved precision, quality, and impactfulness, relevance of what we provide as radiologists to our clinical colleagues. I think that's the reason why people talk about radiomics. It's not the radiomics so much. It's the fact that our clinical colleagues are demanding more precision, more quality, more relevance to our radiology reports. I think the reason why we're talking about AI and deep learning today is because that speaks to the need to improve what we're doing right now. Our existing human-machine IT interaction is not very good. It's primitive. We're going to need some help, a better data-driven, evidence-driven machine-human collaboration, perhaps with AI, perhaps with deep learning, to at least make it feasible, possible for us to provide this service. And I think that's the reason why you hear a lot of this interest or hype about AI and radiomics, because it is this confluence of radiomics saying we need to be more precise as radiologists, and AI saying we need better tools to do it. It may not be AI, but it will be something that reflects the need that we're going to need some help from our machine learning friends so that we can provide precision radiology in the real world, so it's feasible. I think radiomics, this discussion, is just the tip of the iceberg. I think the idea that we want, that our clinical colleagues are demanding, is this idea of precision value radiology. This movement from simply describing crude morphology to much more physiologic, molecular, phenotypic description. This movement from qualitative to quantitative imaging is increasing. This move from generic one-size-fits-all, oh, it's a mass, I don't know what it is, give me my money, to something that's much more specific, actionable phenotypic characterization. And also, we've lost our way. We also need to get back when we were the doctor's doctor, when we interacted with our clinical colleagues more frequently. And now we should interact with our patients, because our patients are no longer passive patients, they are health consumers. And so we need to move between, we have to leave our nice, comfortable reading rooms and be engaged again with our clinical colleagues in a way, and I think IT can help. And in addition to that, we have to do all this increased value and at the same time improve efficiency and reduce cost. That is going to be a very, very significant challenge. And in fact, I think that is the challenge for all of us, not just in Thailand, but all in the world for radiologists. The need and the demand to do greater quality work, but with improved efficiency, reduced variability, and improved quality. I know of no way of doing that than re-examining how we use information technology, including AI. And that's the reason why, even though it's early times, even though it's overhyped, I think that's the reason we're interested in it. I think the danger that many of us have is that we think we've solved our IT issues. Oh, we have PACS, we have speech recognition, we have an electronic medical record, we're good. We're not good. These systems are still very primitive. They're very immature, especially when you compare them to other industries. One of the things I find I like to do is something called intellectual arbitrage. I actually believe we're 10 years behind other industries when it comes to using humans with machines and technology. When I look at other industries, they're far more advanced than we are in medicine. And I think this is one of the reasons why when you look at other industries, they have used artificial intelligence already. They are in their early adolescence, where we're still beginning to crawl when it comes to using AI. And I think the problem with this IT immaturity in medicine and radiology in particular is that it only allows us to provide very low-level service. And we're going to need much more advanced data-driven IT to provide this precision radiology. Now, to give you some examples where I think the existing technology that we use in radiology is still suboptimal, I don't think there's a big difference between how my father practiced radiology and how we practice radiology today. We still require, even though we are electronic and digital based, we still require humans to remember to do things. Other industries don't do that. We do. And that results in inefficiency and variability. We waste precious humans to do mundane things, okay? Looking for images, looking for the T1 images, looking for clinical history. That's busy work. That's distracting. We're using humans to what I call do minimally heuristic tasks for natural language processing. In other words, I use my residents at University of Chicago to look at the electronic medical record to get clinical context. Because in the old days, we didn't need to do that. Because in the old days, the clinicians talked to us several times a day. Now, I need my residents to go and get information from the electronic medical record. This is unnecessary, should be unnecessary. Other industries don't do that. We require humans, as I said, to look for other information that in the old days came to us automatically because we truly collaborated with each other. Now we have to do it ourselves, and that wastes time. I will make the argument that this is drone work. You know, when people talk about, oh my gosh, we're going to be replaced by artificial intelligence, I say, thank goodness. You know, because I don't want to do the drone work. I want to be an executive decision maker. And that's the promise of artificial intelligence. Not that it's going to replace us, but it's going to replace the tedious drone work that we have to do now so that we can be more executive decision makers. I believe this current imperfect human-machine collaboration is threatening to human radiologists. And if artificial intelligence is incorporated using our existing immature models, that's when we can be threatened, and that's a problem. So that speaks to the question, will AI make radiologists obsolete? Well, one of the reasons why we talk about that is a few years ago, one of the giants in artificial intelligence, Professor Hinton, he was one of the first laboratories, his group was one of the first laboratories to use deep learning for images. And he showed that it was very, very successful and outperformed traditional machine learning methodologies. He had a very famous quote. I don't know if you have do you have Wile E. Coyote and the Roadrunner here? Have you ever watched this cartoon? This is a very popular cartoon in the States. And basically he was saying that radiologists are already like this coyote. He's already off the cliff. He doesn't know it yet. He basically saying radiologists were already obsolete. And he basically said they should stop training radiologists now. So all you residents of the room, you should go to lunch right now. Okay, because we don't need to train radiologists anymore. This is an example of one of the most arrogant and ignorant statements that has ever been made when it comes to us. And it's classic for people who are very brilliant in their field and have no understanding of what we do. In fact, he actually, a couple years later, said, you know, maybe I overstated. And he actually reevaluated his comment and said, well, we're not going to replace radiologists, but the role of radiologists will evolve from doing menial perceptual things that could probably be done by a pigeon to doing far more cognitive things. Now, this I disagree. This I agree with. I think this is closer to what's going to happen, that we're actually going to get rid of the menial, mundane drone work to allow us to be executive decision makers. Now, ironically, this concept of deep learning and artificial intelligence and radiomics is also related computationally. It turns out that deep learning, AI, and radiomics use fundamentally the same kind of statistical methodologies. And like I said, I'm not going to give a talk on how AI or radiomics actually work, but trust me, it has very little to do with neurons or neural networks. That is a reflection of a very primitive, incorrect, oversimplified view of how our neurons work. This is deep learning and radiomics is closer to logistic regression, curve fitting, nonlinear curve fitting. So if you want a 5-second explanation of deep learning, nonlinear curve fitting. There. That's more intellectually honest than when you see a bunch of neurons and all that. That's essentially what deep learning is. Now, it turns out that radiomics is the same thing. It's using statistical regression technologies to see patterns, to see that if we can be much more precise in our phenotypic description. We've done this for 30 years, nothing special. And that's why I'm a little bit skeptical about radiomics. We've basically given a new name to an old technology that we've done for decades. It's not about AI potentially replacing radiologists. It's about AI is just one of the many advanced IT tools that I believe we need to help us provide more precision radiology to support precision medicine without burning out. It's how existing IT immaturity and this existing human-machine dissonance is harming our ability to provide precise and value radiology, to optimize value to a radiologist. Right now, our existing tools are too immature. What I believe is we should not be talking just about AI or radiomics. AI is just one of many tools. I get bored with tools. I'm a radiologist. I'm an interventional abdominal radiologist. I'm not a CT guy. I'm not an MR guy. These are tools. There'll be more tools, all right? These are capabilities. I am a clinical radiologist, not a CT person. That's why I'm not comfortable talking about AI and radiomics. These are just tools. AI just reflects that we need better tools. Radiomics says we need precision radiology, all right? So I would rather make the recommendation that it's overhyped when we talk about AI and radiomics. We should basically saying we need to be the doctor's doctor again. We need to be relevant. We need to perform precision radiology, and we're going to need better IT tools to do it, including AI. This leads me to something that is an old topic. Before computer science, before artificial intelligence, there was the field called cybernetics. That's essentially what I'm talking about here. The word cybernetics comes from the Greek word meaning to govern. okay, to steer, to orchestrate. The field of cybernetics came before computer science and AI. It's basically the idea of how humans and machines should optimally work together. We are all cybernetic organisms. I wear glasses. Many of you do. Most radiologists do. We look too close to the screen. This is an example of human-machine collaboration. In many ways, you could make the argument that what we do with our PACS systems and with AI are examples of human-machine cybernetic collaboration. I make the argument that our human-machine cybernetic collaboration today is inefficient. It is immature. And as a result, we need to improve that. But it's not improving the technology alone. It's changing and re-engineering how we radiologists work with machines. So it works both ways. The goal is data-driven human-machine harmony, collaboration. Because humans and machines have complementary strengths and weaknesses, as you can see. These are pretty obvious things. But when you look at these characteristics, humans and machines are very complementary. We're not going to replace one another. We need both together. But we need them designed in a way that places in advantage what humans do and puts to advantage what machines do. One of the problems that I see in radiology and in medicine in general is we don't use machines correctly. Unlike other industries, we use machines, including AI and advanced information technology, to make humans look worse. And that's the wrong way to do it. Other industries use AI in a different way. And that's what I'm talking about, meaningful IT innovation. That's what we want. So in a few minutes, I'm going to give you examples of how what we have done at University of Chicago and other places have used to try to re-engineer, redefine how humans and machines should work together, and how we can use things like AI to do this. But this is not an AI talk. It's how we can be the doctor's doctor again by achieving data, evidence-driven human-machine collaboration. AI is just one capability, okay? So here's an example. Let's look at workflow. Many of us as radiologists don't realize that when we talk about radiology, the clock doesn't start in the reading room. It doesn't start with us. It starts when a clinician, when she believes an imaging study may be contributory to the care of her patient, and only ends when that physician gets a collaborative message from me. Now, as a result, a lot of the variability and inefficiency and errors occur before the images even get to me in the reading room. And if we're going to use optimized human-machine collaboration, perhaps we should start not in radiology, but way before. And that's why I always show this. It's more than just what goes on in our PACS workstation, okay, in imaging. So here's an example. You know, when you look at our PACS systems, we're pretty inefficient. But when you look out in the scanning area, this is a scanner that can scan you head to toe in a few seconds. But what's wrong with this picture? Does anyone know what's wrong with this picture? It's empty. No one's in it. And that's one of the problems. It's too easy to take this picture. In the beginning years when I was invited as a visiting professor, I would always go and take a picture to show it was too easy to take a picture of an empty scanner. All right? Because if a scanner is empty, there's inefficiency. In fact, unfortunately, I don't do that anymore because everyone knows, oh, Dr. Chang's here. He's going to take a picture of an empty scanner. Hurry. Put someone on the scanner. And so a technologist or a nurse would just jump on the scanner and say, no, it's not empty. But that's a problem. It's too easy to take this picture. But the real question is, why is this scanner empty? And the reason why it's empty is because we require the humans and the machines don't work well together. We depend on too much on the human to make certain decisions, too much variability. So it takes them 20 minutes to set up a CT scanner or an MR scanner. The consequences are not just inefficiency, it's quality. As you know, if I do the wrong protocol, I'm going to miss this metastatic neuroendocrine tumor. I'm going to certainly understage it, correct? So it's more than just efficiency, it's also quality. So a number of years ago, one of the things we built was a machine learning system that first gave electronic protocol But the more important thing was, it also gave us the ability, in order to protocol, you need to provide the machine learning algorithm clinical context. You need to give contrast allergy, if there's a leukocytosis, if someone mentioned cholangiocarcinoma, for example, which means now I have to get a delayed series to do that. You need to have access to clinical information. So one of the challenges we had to do when we built this was develop methods to extract information electronically from our electronic medical record to build this. Now, why did we do this? We did this so that we could treat the CT scanner, replace the human. The human was adding anywhere from 20 to 30 minutes setting up an MR to CT scanner. Instead, with our system programmed the CT scanner automatically. So instead of 20 minutes to set up the scanner, it only took 500 milliseconds. And no matter how complex the protocol, it always did it right. We did this, we published this a number of years ago, and what it showed is when every other day we used our system, our IT system, machine learning system. Now, on days the human did it, it took a long time to do each study, and if this is the reason why it's too easy to take a picture of an empty scanner, because the limiting factor is not the scanner. The limiting factor is your human technologist not being used efficiently. When we used our system, now we were able to reduce the time by 70%. This is a non-trivial example. But it's more than just improving efficiency. It's also making sure the right protocol was done, no matter where the scanner is. And that's an advantage. So this idea of data-driven, real-time image acquisition and workflow orchestration is a huge potential benefit of artificial intelligence. I predict that one of the early uses of artificial intelligence, especially deep learning in radiology, you won't ever notice it. What you'll notice is that your MR scans are now 40% faster, because people are now using and embedding into their scanners deep learning systems to reduce reconstruction times. You're going to see protocols being managed for radiation exposure optimization, not post hoc, not using analytics, but rather using machine learning to optimize dose at the time of acquisition. That's my prediction. So AI is going to be used very, very soon, but we in radiology in the reading room may not even recognize it, because it's going to be used to improve efficiency and reduce variability and quality. Going back to the reading room, though, another example of using advanced IT is, let's look at the work list. You all have work lists. The problem is your work lists now only tell you what the PACS and the radiology information system knows, and that is stat ER cases. This work list is different. This work list that we use actually also says you need to read this one first because this patient is scheduled to be discharged today. You need to read this one because this patient is going to be seen in clinic in an hour. In other words, improving the efficiency and quality for our clinical colleagues. Again, being the doctor's doctor. And just a few months ago, we added another alert. The artificial intelligence algorithm detects that this CT scanner has an intracranial hemorrhage, or has free air, or has a rib fracture. You might want to look at it first. And that's another, my prediction is you're going to see some of the early applications of AI in the role not to replace you, not to make the diagnosis so much, but to triage, to identify cases before you're too fatigued, where you need to be actionable, to interpret these first because they're having abnormalities. That's one of my predictions. As I mentioned before, we are incomplete and imperfect observers as radiologists. As such, Bayes' theorem applies, that the posterior probability is a function not only of the performance of the radiologist, but on the prior probability. And that prior probability is clinical context. We published a paper a number of years ago that an unintended negative consequence of the electronic medical record is that our clinical colleagues don't tell us anything anymore. Everyone just has belly pain. They don't tell us they have cancer. They don't tell us they have Crohn's disease. They don't tell us they have TB. We actually published a paper to try to quantitate that. And what we found was it was frightening. Almost 10% of the time, our clinicians don't even tell us they have cancer anymore. There is no way I, as a human radiologist, can interpret an image because I'm an imperfect observer unless you tell me the patient's clinical history. and yet they don't have it. In the old days, when we were the doctor's doctor, in my father's generation, before PACS, this was not a problem. They told us everything about the patient. We knew more about the patient than they did most of the time. And now this is a problem. Okay? So how can advanced IT technology, including artificial intelligence, can help here? Well, here's something we built 13 years ago. We have the ability to extract real-time all the information from our electronic medical system, because I don't live in my electronic medical system. I live with my PACS. So I don't want to waste time going to the electronic medical record system or calling someone for history. So we wrote software that allows us to extract the information directly from that. The problem with that is we still have to read all this, and it's presented in an unintelligent way. Here's an example. This is directly from a patient, the active problems from the electronic medical record. And if you notice, it's essentially the most recent finding. Well, unfortunately, the most recent finding is not interesting to me, because if the patient has a diagnosis of a cancer, that's probably going to be an earlier finding. And one of the problems with electronic medical record is that the problem lists, all of them, I won't mention names, but all of them, are unintelligent. They don't use machine learning or AI. So that's one of the first things we did. A number of years ago, we actually applied artificial intelligence, and it's called an LSTM, long short-term memory recurrent neural network. It's a form, a variation of deep learning, to actually take that problem list and basically said, oh, you're looking at an abdominal study, you're an abdominal radiologist, this is probably what you need to know first. So this is a simple application. Now, I don't feel threatened by this. This is an example where I don't think this is threatened. This is a better example of more positive human-machine collaboration. The machine can automatically know what I'm doing, help me rank the problems in an area that makes, in an order that makes more sense to me. So that's an example. Here's something that we're about to deploy. That's great, but I still have to read it all. Why not use deep learning to read everything, the whole electronic medical record, all prior reports? And this is what we're ready to deploy. This is an example of deep learning that says, oh, we'll read everything. Here's what you need to know. This patient has lung cancer. This patient has a leukocytosis. The lactate is elevated. And someone mentioned 2 CT reports ago that you should pay special attention to that segment 2 mass in the liver. Now, humans could do that, but we do it poorly. We're very inefficient doing it, and we miss things. Humans are terrible at missing things machines can do this better. So again, this is not replacing us. This is an example of more optimal, data-driven human-machine collaboration, cybernetic harmony. All right? Let the machine look at all the old reports. Let the machine look at all these lab values, determine what's important, and let me, no longer the drone doing it, let the machine be the drone worker. Let me be the executive decision maker. This is not replacing. This is augmentation. This is collaboration. This is cybernetic harmony. I'm an oncologic imager. I do a lot. Most of my patients have cancer. And one of the things I have to do, which I hate, but is important, is resist measurements. How many of you love doing resist measurements? How many look forward to doing resist measurements? Of course not, because it's terrible to do. You have to read the old report, you got to, oh, it's horrible. So one of the things we did years ago is we used machine learning to say, look, we can identify all the priors. I don't have to read the report. Show me what the prior reference lesion was. Tell me where the new one is. I'll do it and automatically put that into a report. Okay, we published this in 2015. This improves efficiency by 40%. So it not only improves efficiency, it also improves the quality of my resist measurements. Okay? So again, this is an example of data-driven human-machine cybernetic harmony. AI is just a tool. The goal is human-machine cybernetic harmony. Doing what I do best. I don't want to be a drone. I want to be an executive decision maker. I'll show you more of that when we talk about collaboration. In the old days, when we were the doctor's doctor, we collaborated. Yes, it was inefficient. Everyone had to come to the radiology department. We need to use modern technology and collaboration and social networking tools to collaborate with our patients, our health consumers, and our physicians again. This is something my son showed me many years ago to explain and convince me why I had to pay for an unlimited data plan for him and his sister on it with their phones, okay? Basically, our children have 20 ways to communicate using social networking about nonsense. And we in radiology only have a report, message in the bottle, and a phone call. In order to be the doctor's doctor again, we need to embrace the same tools our children do for collaboration as well. Here's an example. One size doesn't fit all. We need to pick the right tool to communicate and collaborate. Remember I showed you this tool we built a number of years ago to help make measurement of oncology lesions faster. The problem was we dumped it in the report. We basically put them in the report. So it improved our efficiency. It reduced our error, but it still required the human oncology team to cut and paste those measurements, and it resulted in a 9% error. So even though the tool using AI helped us in radiology, because we used the same message in the bottle, we dumped the measurements, the resist measurements in the report, it didn't help our clinical colleagues. They could still create errors. In fact, this was dangerous. When we published this, we showed that because of this cut and paste transcription error alone, it resulted in 3 patients getting the wrong treatment with cancer. So this is a real problem. Incomplete, immature human collaboration with machines. So what did we do to do that? Instead of using the report, we said there's a better way to communicate resist measurements. So we built this. This is an example of what we call the oncology dashboard. This is how our oncologists look at images now. Notice they don't actually read the measurements. They have the index measurements tracked temporally because that's how they think. Are the lesions getting better? Are they getting worse? Now, if you hover on this data point, the image will pop up on the screen so they can actually see. What I'm showing an example is that we have to go beyond. In order to be the doctor's doctor today, we have to use our children's IT tools and go beyond just the report and the phone call. We need to be polymorphic. We have to be flexible in how we express our findings. It just cannot be a report. We have to go beyond the report. Now, the problem is, I don't have time to create this. But AI can. Machine learning can. It's trivial. It's simple. Again, not replacing me, but augmenting me. Human-machine collaboration. Here's another example. One of the things that we in the University of Chicago and you all recognize is the fact that cancer, when it metastasizes, there is much tumor heterogeneity. First described in breast, as you know, a breast primary may be triple negative, right? But the metastasis may actually mutate to express estrogen receptors or progesterone or HER2. We have now described it in almost every cancer. Mesothelioma. At our institution, my group, we actually showed that gastroesophageal carcinoma also has tumor heterogeneity. That's a wonderful thing for me as an interventional radiologist. It means I can biopsy a lot now, okay? But the problem is, what that means is resist measurements are an oversimplification. They're incorrect. They're not the complete, precise measurement. So, for instance, the resist measurement was designed because it recognized human limitation. Resist measurement says humans can't possibly measure every metastasis. So, pick a representative lesion. And that's the resist measurement. Okay? We all use that. Here's the problem. This is the same patient. I biopsied every one of these lesions. This is a machine learning AI tool, deep learning tool, that looks at every single metastasis, measures the volume temporally to determine if there's change. The lesions in green are getting smaller. The lesions in yellow are stable. But these lesions are increasing in size. I make the argument that what we're doing now with resist measurements is an oversimplification designed to address the limitations of humans, but is not adequate for precision radiology. In order to provide my oncologist precision radiology in the world of tumor heterogeneity, I need to give him this. I need to give him or her the ability to know what lesion should I biopsy to determine the genetic profile to hopefully tailor precise therapy to that. We can't possibly do that as humans. We're going to need advanced technology like AI to do this for us. Okay? So again, this is not replacing us. This is augmenting us, providing data contextually driven human-machine collaboration. That's the goal. Data and contextually driven human-machine collaborative workflow orchestration. Now, how do you do that? Well, that's going to be hard because our existing systems don't. I don't have time to talk about that. This is the system that we have built in Chicago. Basically, every single study that comes to the scanner not only goes to the PACS, but goes to this AI engine that basically in real time is determining what can I do to help my human partner. So here's an example. One of the biggest problems we have stateside, and I'm sure you have this as well, is the concept of what do we do with incidental findings? When I see a nodule in the lung, we know the majority of them are going to be benign, but a small subset of them are going to be something that needs to be treated. They're going to be a cancer. How do I follow that up? How do I even recognize what needs to be followed up? Right now, we require humans, yes, to do that. All right? That's a problem. All right, because humans are not good at that. That's a mismatch. That's not optimal human-machine cybernetic harmony. Here's a tool that we're about to deploy. What it does is if the human detects the nodule, which humans are pretty good, machines can do it as well, but I don't want a tool that I'm pretty good at that. Our chest radiologists are very good at that. Here's what they're terrible at. Remembering and looking whether or not the patient has a smoking history, remembering the latest recommendations. So basically what this does is as soon as the human detects the nodule, the AI tool real time says, hey, you just detected a nodule. Let me check to see if the patient has a smoking history. Oh, and it's over 6 millimeters. We need to follow that in 6 months. Let me automatically put that in the database to automatically follow. You see that? Humans are terrible at remembering, oh, we need to follow up this nodule in 6 months. Computers are very good at that. This is an example of the appropriate use of artificial intelligence. Here's another example. I've done a lot of observations of how human radiologists look at MR, and everyone cheats. If you're a neuroradiologist, you look at the flare, you find the abnormality. And then what do? You play a game that children play. Where's Waldo? Where is it in every other sequence? Why should we do that? That's drone work. Machines can do it better. So as soon as the human says, this is the lesion I'm interested in, let the machine, the cybernetic harmonized machine, find it for you, automatically determine if there's enhancement, or automatically do the subtraction for you instead of the human. You get the idea. Human-machine working together, not to replace one another, but to augment, to make humans look better. Okay? To no longer do the drone work. Now, that sounds wonderful, but it's not going to happen today. These are very early times. So I'm going to finish this talk by telling you the challenges of why it's hard why my lab, we had to build all this software ourselves because we couldn't buy it. I would much rather buy it, but I can't. And the reason for it is we tend to buy very early in the hype, right? Everyone was talking about AI for a couple of years now, but it usually takes us a lot longer to consume. How many of you have seen this Gartner hype curve? I talk about this a lot. This is classic for every new potentially disruptive technology. AI is no exception. We all go through this overhype, oh, the greatest thing in the world. And then we go and we're disappointed. Eventually we learn how to use it. I'm making the argument right now we're still here. We're still very early in the hype phase. It's going to take a lot longer. Now, there's another law in addition to the hype curve. A lot of people look at this hype curve and get depressed. They basically said this is going to take too long. But what they forget is eventually we get there. Eventually we learn to appropriately consume technology. My prediction is we eventually will learn to consume artificial intelligence appropriately. And people forget that. And I always remind people there's another law called Amara's law. We tend to overestimate the effect of technology in the short run. In other words, we overhype it in the beginning. However, we always underestimate the effect in the long run. In other words, yes, we'll overpromise, overhype. It's going to take a lot longer, but eventually we won't recognize how it dramatically changed our lives. And that's what's going to happen. Now, one of the reasons why it's going to take longer is it's going to take us longer because there's some challenges to artificial intelligence, especially deep learning. Because the word deep is very good, because it means not only capable, but also obscure. I don't want to get into this because remember, deep learning is essentially nonlinear curve fitting. But the problem is how it does it is not obviously understood. And as a result, validation can only be done statistically. In other words, you have to have enough numbers to do this. And the problem is not just enough numbers, it's are the cases that you trained your deep learning system representative? And the algorithm that you develop, can it be generalized? And that's the problem. How do we avoid overfitting? This is an example of overfitting. This is Google's ImageNet deep learning system. It's one of the best deep learning systems that exists for images. That system thinks that is a gun. Now, I don't know how old you are, but you may not know that's a turtle. You may say it's, I don't know what it is. It's an animal, a reptile. But no one in this room, no human, no child would say, that's a gun. And yet, one of the best AI systems, better than anything in medicine right now, thinks that's a gun. Okay? That's an example of overfitting. Overfitting is this. Here's the identical data set. The challenge we have with deep learning is early deep learning tends to do this. So it works beautifully for the data that you trained it with, but it can't be generalized. And that's a problem. In fact, this is a very important paper. It just came out this month. It's a paper from the KJR, from the Koreans, that basically this is the first meta-analysis. It's a very nice paper. I reviewed it. It's a meta-analysis of all the AI in radiology now, the images. And their conclusion is not so good. Their conclusion is we have not demonstrated that we can generalize these algorithms. Again, we'll get there, but these are very early times. Here's another reason why it's going to take longer. To me, a machine learning AI deep learning algorithm is like having the fastest race car, which is perfect because right across the street there's an auto show, isn't it? Okay. Well, it's like having the fastest, fanciest car out there. But the problem is even the fastest, most capable car requires gas and roads. And in this metaphor, in machine learning, gas is data, vetted data, and the roads are workflow orchestration. That requires a very sophisticated IT infrastructure, and we don't have it. And that's the other reason why it's going to take longer. The holy grail is data interoperability. One of the problems here is if you look, the vast majority, in my mind, as a clinical radiologist, most of the AI algorithms don't interest me. They're kind of pedestrian. They're kind of, I don't care. Lord knows I don't need another bone age algorithm. I don't need another pulmonary nodule algorithm. There are better, more traditional methods for detecting nodules. And I don't care if you're going to characterize them because no one's going to trust you anyway because it's not our role as a radiologist to make that specific diagnosis. The problem is deep learning algorithms are being driven not by, oh, this is useful, but rather the data are available. The reason why you have so many bone age algorithms is because the data are available. Every single radiograph of a kid's hand has proof, the patient's age. So these systems need vetted data. You have a lot of gas. Same thing with lung. We have data sets with lung cancers. So the problem is, can you generalize that to the general population? I don't know. So that's the catch-22. I'm not going to spend the time to give an advanced IT infrastructure unless you give me a compelling use case. But I can't build a compelling use case unless you give me the IT infrastructure to give me the gas, the data, or the workflow orchestration. So that's the reason why it's going to take longer. We don't have the IT infrastructure to do this because right now hospital IT infrastructure is very primitive. It's EMR-centric. We really don't have data mining capabilities. We require humans to be the integrating agent. In order to embrace AI, we're going to need machines to be able to access the information. So that's a problem. This is the infrastructure we built in University of Chicago. It's one of many ways that we're trying to become more AI ready. So in summary, I want you to stop thinking about AI or radiomics alone. That's like saying I'm a CT or ultrasound person. No, I am a clinical radiologist. That should be the doctor's doctor again. I am relevant, I am impactful, and I understand that I need to provide more precise radiology to support precise medicine. But in order to do that, I need better human-machine collaboration. Radiomics and other aspects of precision radiology are going to make great demands on us. Our existing IT tools are inadequate. Do not be seduced by hype like AI and radiomics. The goal is optimized, data contextually driven, human-machine cybernetic workflow orchestration harmony. While it's too early to pick a winner, we need to embrace and understand that we need to re-engineer our IT infrastructure to consume these new technologies. And here's the most important thing. At dinner last night, I actually asked, you know, how do people do, and you're just the same as my country. We radiologists buy our packs. We buy our tools, and that's it. We don't influence, we don't drive. We have to be at the driver's seat in this. We have to be in the loop. We have to engage. We have to force our IT colleagues to say, this is the way we need to use artificial intelligence. Because if we're not in the driver's seat, we're going to be locked in the trunk of the car, and we won't have control where we're going. Thank you very much.